This is kind of a poach case, and I have some questions. It's a 30-year-old prima gravida who was from Pakistan and moved to the UK 24 months ago. There was no relevant past medical family history, and these were her booking bloods. So she was deemed low risk and sent to the community. However, at just under 36 weeks, 30 weeks pregnant, she presented with a 7-day history of breathlessness, orthopnea, tachypnea, hypoxic and hypertensive, and some pedal edema. These were her bloods done in the emergency department, and a hemoglobin of 156 is still high, and at this point her platelets had dropped. She had proteinuria, raised liver enzymes and brisk reflexes, and you're thinking, what's this got relevant to do with an echo course? So any thoughts? Preeclampsia. Preeclampsia is possibly common, and therefore we think she thought she had preeclampsia or possibly a PE. And she went to delivery suite, where she had labetalol and magnesium sulfate. When they actually listened to her, she had loud second heart sound and an audible third heart sound, and her ECG had a right ventricular strain pattern. I haven't got these images because this was all done at a separate hospital. A bedside echo supposedly showed right ventricular hypertrophy, which he said was in keeping with the normal hyperdynamic circulation of pregnancy. Normal LV function, normal PA pressures, and no valve lesions. Any further thoughts? The normal echo features of pregnancy, you get a hyperdynamic circulation. The chambers are on the upper limits of normal, be the LV dimensions, and they can get diastolic dysfunction, especially if they've got hypertensive disease of pregnancy. But the right ventricle may be hyperdynamic, but relatively normal in size and certainly not hypertrophied. So, she went into type 1 respiratory failure, and they thought she was developing pulmonary edema. So she had some steroids and some platelets, because everyone gets spinals to have babies nowadays. They maintained her on a phenylephrine infusion, and she was stable and had a baby boy. So it was deemed uneventful. So you're again wondering, what are you doing here? She went back and continued treatment for presumed preeclampsia, or PE. But she became increasing oxygen requirements. Supposedly chest x-ray was okay, but then she decompensated. She was quite hypoxic, cyanosed, became drowsy and hypotensive. Took a few seconds and resolved, but then had further episodes. So she went to the intensive care unit via radiology, and this was her x-ray. Any comments? Sorry? Yeah, this part is certainly fairly prominent. I wouldn't like to say whether that's a pulmonary artery, but certainly the aorta or the pulmonary artery and this side of the border. But there's no real evidence of heart failure, I wouldn't have said. It's not gross pulmonary edema. She didn't have a PE, but she did have ascites, and she did actually have evidence of pulmonary hypertension. So you're right saying that the pulmonary artery was big and evidence of right heart failure. She decompensated again, and they decided to review the echo images and found that the PA pressure was 100 millimeters of mercury and that the PA was 2.6. She had right ventricular pressure overload but no shunt, and so they thought it was idiopathic pulmonary hypertension. She then became peri-arrest, extremely unwell, and needed intubating. They started some iloprost and milrinone, but she was needing boluses of adrenaline, noradrenaline, and dobutamine, and that's where we came in. We run the ECMO service for, it was actually fairly local, this patient, the Northwest. So they did a bedside TOE with the bubble test that was negative, and they still had the same working diagnosis, deemed ECMO was not appropriate, but transferred to us for specialist care. We gave her inhaled nitric oxide, which supposedly proved her PA pressures. So these are her echo images.